Nuestra historia comienza en Alstaten, Suiza, con un puñado de productos de inmejorable calidad. El sueño fue creciendo y con él cruzamos fronteras de innovación tecnológica, geográficas y generacionales. Con la vocación de servir a la comunidad odontológica con productos de calidad que contribuyan a la salud bucal de sus pacientes, alcanzamos grandes resultados y hoy estamos presentes en más de 180 países del mundo. Nuestro liderazgo en Latinoamérica y el Caribe se basa en 3 pilares: productos confiables e innovadores, el mejor equipo de distribuidores de la región, que nos vincula con odontólogos de 27 países, y una historia de interrelación con las escuelas odontológicas, hoy denominada Coltene School Program, que dio origen al foro educativo Coltene School y Forum, una plataforma e-learning y un puente de comunicación entre las escuelas y la comunidad odontológica latinoamericana. Nuestra contribución a la educación continua y evolución profesional de los odontólogos de cada rincón de la región. Unimos Latinoamérica con el resto del mundo, sirviendo a cientos de universidades, miles de odontólogos y millones de pacientes. En Coltene sentimos a Latinoamérica como un todo, una región única, diversa, pujante y entrañable. Porque en Coltene somos Latinoamérica.
Welcome everybody to Coltene School e-Forum. I'm Antonis Chaniotis reporting live from Buenos Aires, and I'm really excited to be here because I'm going to discuss with you one of my favorite topics, that is how to optimize your control instrumentation for complicated root canal systems. So from the beginning, I'm telling you we're going to see a lot of complicated root canal system instrumentation. And in order to get started, let me remind you all some of the major goals of root canal treatment. As you all probably know, of course, the major goals of root canal preparation, of root canal treatment, is the prevention of periradicular disease and the promotion of healing in cases where disease is already established, right? And root canal instrumentation arguably plays a major role to the accomplishment of this objective through the removal of all vital and necrotic tissue, not only from the main root canals, but also from the lateral extensions of the root canal system, the creation of sufficient space for irrigation and mitigation, right? The preservation of the integrity and location of the apical anatomy, the avoidance of any heterogenic damage to the canal system, facilitation of root canal filling, avoidance of further irritation to the periradicular tissues, and the preservation of south root dentin to allow the long-term function of the tooth. So, in one hand, with instrumentation, we need to create sufficient space for irrigation and medication, right? But on the other hand, we need to preserve sound root dentin to allow the long-term function of the tooth. So, how do we decide about the minimum instrumentation requirements for maximum disinfection for every case? If you search the controversy of apical enlargement in the literature, you will find all these articles. Mainly, there are two main philosophies. One suggesting smaller apical preparations and larger tapers, and the other one suggesting larger apical preparation and smaller tapers. Very recently, there is a new instrumentation philosophy that people used to call it the minimal invasive instrumentation philosophy, that is suggesting smaller apical preparation and smaller tapers. So, no matter which instrumentation philosophy you follow, I believe you will all agree with me that ideally, we would like our root canal preparation to follow the exact outline of the horizontal dimension of the root at every level of the canal, by simultaneously preserving enough circumferential dentinal thickness for the tooth to function and survive, and without jeopardizing the disinfection of the apical third. So our instrumentation size in every case will always depend upon the anatomy we are dealing with and upon the disinfection technique we are using. If you search in the literature about the minimal instrumentation requirements for effective disinfection, most papers will agree with Academy and colleagues here, like in this paper that you can see over here, that you need at least a minimum apical instrumentation size of 30/6 for effective irrigant penetration to the last apical third of root canals, or even larger, because always larger apical preparations will result in more irrigant volume to the apical third and may be cleaner canal. In these canals, in this paper, increasing the size of the preparation from 25/08 to 40/04 or 06 with irrigation resulted in less hard tissue debris accumulation in the isthmus area and cleaner canals. And if you want your irrigation needle to reach to the last apical millimeter, you need to enlarge the canals at least up to 30, because if you are using a 30 gauge irrigation needle, you need space to drive this needle to the last apical millimeter. And you need to do that, because if you don't do that, if you don't enlarge up to at least a 25/08 or a 30/04, probably your irrigation needle will stay 4 to 5 millimeters short of working length. And then there is a lot of debris you are going to leave behind. So if you have a case like this, let's suppose you have a maxillary incisor like this. Huge canal, straight canal, very easy case. I don't think anybody in this room needs special metallurgy and sophisticated instruments to manage this case. I mean, if you need, you're probably in the wrong school, right? This is the easiest case you can ever have. You can achieve quite easily with all instruments available your ideal instrumentation. You can clean this canal, you can shape this canal and obturate without any significant problems. The problems of instrumentation begins when the anatomy goes like this. What do you think about this now? It's not the same, right? I have a straight part of a canal and then the canal deviates abruptly distally, or even more complicated anatomies. Check out this one. I mean, how can you achieve a 30/04 preparation in a double curved canal like this one? And which instrument to use? And which technique would be the most safe and predictable to use? Or check out here the anatomy, delacerated mesiobuccal root canal system with a huge periapical lesion. Somehow you need to create space here in order to disinfect the apical third, or in complicated cases like this. how easy it is to achieve this result in extreme curvature like this one. If you can see the video, I'm not sure if you can see it right, probably you can see it frame by frame, but you will see the plastic deformation of the GP cone. Check out this now. This is the curve we're talking about. How can you achieve an adequate instrumentation size in canals like this without transporting the canal or breaking an instrument inside? The way I see it, in cases like this, we are facing two major problems. One is the problem of transportation and all the undesirable results of transportation, like ledging, perforation, or strip perforation. And the other problem is the problem of breaking an instrument inside the complicated anatomy rise. This is what we all are afraid of. Let me start from transportation. What is canal transportation? According to the glossary of the endodontic terms, canal transportation is the removal of the canal wall structure on the outside curve in the apical half of the canal due to the tendency of the files to restore themselves to their original linear shape during preparation. For stainless steel hand files, this is the tendency of the file to restore themselves, right? You bend the file springs back to normal. Now, if instead of the ISO 10K file, you get an ISO 25K file, you will increase the metal mass of the stainless steel file and you will have more restoring force. Besides stainless steel hand files, control memory, hand and rotary files, conventional nickel titanium hand and rotary files, and some heat-treated nickel titanium files, they also have restoring force. You bend them, they spring back. The only difference is that nickel titanium can accommodate greater stress without increasing the strain. That's why nickel titanium alloy was used for rotary instrumentation. Now, if root canals were constructed precisely on the dimensions of our instruments, all the instruments would be well constrained inside the precise trajectory. And even instruments of different design would maintain the parameters of curvature unaltered. However, usually instruments are not well constrained inside a precise trajectory because the canal is not precisely shaped to fit their dimensions. Moreover, the more the instrument cuts and removes dentin in a curved trajectory, the more loose it gets inside the trajectory, and the more the instrument tends to straighten itself. So usually, each instrument may follow its own trajectory inside the canal, guided by its restoring force and altering the parameters of curvature. And how transportation is produced? Transportation is produced when a rotary file is rotating around the curved canal and the tip of the file is smaller than the canal. In this video, you can see, probably frame by frame, but you will see that this file will not transport the canal until it reaches length, but when it reaches length and you stay there with the file rotating, it will transport the outer apical canal wall. Why? Because of the restoring force of the instrument, and it will give you this shape that you can see in the screen. This is the definition of transportation. And the more you increase the size of your preparation in a curved trajectory, the more off-centered preparation is achieved. Check out this in this paper. If you increase your preparation from 25 to 30, 45, and 50, how eccentric the preparation gets. Huge transportation for ProTaper Universal, smaller transportation than M2, and of course even smaller for nickel titanium hand files. But it's not only the size of your instrument, it's also the taper of your instrument. Now, if instead of a 2504 tapered instrument, you take a 2506 instrument, like in this video, you will see that only one time this file went below the curvature and now the file is ledging the canal. Why? Because by increasing the taper of the file, you increased the metal mass of the file and you increased the restoring force of the file. So this file cannot navigate around abrupt curvatures. And this is the clinical analog of what we are talking about. This case, highly curved mesiobuccal canal system, this tooth was extracted because of failure of the doctor to navigate with greater tapers and greater sizes around this abrupt curvature. I sent this extracted, highly curved tooth to my friend Ronald, that was in Brazil back then, and make this fantastic micro CT in order to find out what went wrong with the instrumentation in this case. And you will clearly see that the problem was that the canal was ledged. So the doctor couldn't negotiate around the abrupt curvature, tried for 5 subsequent appointments until the tool fractured, collapsed, and the tooth was extracted. We don't want for your instrumentation of highly curved cases to end up to Ronald or Dinola Zapata micro CT because of failure to navigate around the anatomy. You can see here in the axial slices how the ledges look like in the MB2 canal system. The canal is almost perforated. Why? The driving force of transportation is the restoring force of the file. Besides transportation, the other major problem for the instrumentation of complicated cases is breaking an instrument inside, the curved trajectory, right? There seems to be 2 mechanisms of rotary instrument separation. One is cyclic fatigue and the other is torsional failure, or a combination of both. What is cyclic fatigue? While a rotary instrument is rotating inside the curve, continuous, compressive, and tensile stresses may lead to instrument separation. And this is failure because of cyclic fatigue, or we call it bending failure. Bigger file sizes are always less fatigue resistant. So the more you are trying to increase the apical enlargement in a curved trajectory, the more you risk instrument separation because of fatigue failure. Torsional failure, on the other hand, is the result of an applier shear moment exceeding the elastic limit of the material, producing plastic deformation and ultimately a fracture. And this may occur when the tip of the instrument is locked, like in this video, outside the foramen or in a narrow canal lumen, generating high torsional loads. Smaller files are always very prone to torsional failure, but more fatigue resistant. So the smaller the instrument, the more you risk torsional failure of the instrument if your file gets locked inside the canal and the motor keeps on turning. And we know from many publications in the literature that the more complicated the curvature, the more the risk to break an instrument inside. For example, in this paper, the result of this paper confirmed that the numbers of cycles before failure significantly decreases as the complexity of the curvature increases. So, let me ask you the question. How can you achieve what we call anatomically driven preparation in complicated canal system like this one? I mean, these are some of the most difficult cases for instrumentation. And I'm here with you today and tomorrow in COSAI meeting to discuss with you not how to shape a straight canal, but how to approach cases like this. I mean, how can you enlarge a canal system like this one without destroying the root, breaking an instrument inside, right? Or transporting the canal. If you want to achieve anatomically driven preparations in such complicated cases, you need to have 2 things. You need to have the right instruments and you need to develop a right instrumentation technique. As far as the instrument's concerned, I would like to have an instrument of maximal torsional resistance, right? We all like to have that. I would like to have an instrument of maximum fatigue resistance, of maximum flexibility, and also I would like to have an instrument devoid of any kind of restoring force. Why? Because the restoring forces are the driving forces of transportation. And I would also like to develop an instrumentation technique that will minimize the engagement of the activated file, a technique that will give you a feedback of the anatomy throughout the whole procedure, a technique that can take advantage of the advanced metallurgy, a technique that can give you unblocked visualization of root canal negotiation under the microscope, and a technique that is teachable and reproducible by every dentist. So let me start with the instrument, and then we are going to discuss the technique. Why control memory files? Why use control memory files? As you all probably know, of course, nickel titanium alloy was used in endodontics. It's softer than stainless steel, of course, has a greater strength, tougher and more resilient, but it was used in endodontics because of two characteristics. It shows shape memory and super elasticity. Nickel titanium shape memory alloy can exist in two different temperature-dependent crystallographic structures. One called martensite, or low temperature phase, with a monoclinic B19 structure, and you can see here the monoclinic B19 structure of the martensite, and the other phase is called austenite, or high temperature or parent phase, with a B2 cubic crystal structure. The lattice organization of nickel titanium alloy can be altered either by temperature or stress. This means that martensite can be transformed to austenite and austenite to martensite with two ways: by altering temperature or by stressing the nickel titanium alloy. When the martensite is being transformed to austenite and vice versa, austenite to martensite, the alloy goes through an intermediate phase that we call it R phase with a rhomboidal crystallographic structure. For austenitic, superelastic, shape memory nickel titanium alloys, like the radius vascular stent that you can see here in this video, in body and room temperature, it's austenitic. The external stresses that you apply with your fingers will transform the austenitic crystalline structure into a martensitic one that can accommodate greater stress without increasing the strain. And this is what continuously happens during rotary instrumentation. Austenite to martensite and martensite to austenite. Place your file inside the canal, you are stressing the file, you will transform it because of a stress-induced martensitic transformation to martensite. Take it outside of the canal, your file is again austenite in room temperature. Now, what is the effect of temperature in nickel titanium alloys? In this simple experiment with liquid nitrogen and the glasses, the austenitic glasses, here you can understand the effect of temperature in the phase transformation of nickel titanium alloys. When austenite is cooled, like the austenitic glasses in this video, it begins to change it on martensite. The temperature at which this phenomenon begins is called the martensitic transformation start temperature. And the temperature at which this phenomenon is completed, it's called the martensite finish temperature. When the martensite now is slowly heated back to room temperature, it begins to change again into austenite. The temperature at which this phenomenon begins, it's called the austenite transformation start temperature, and the temperature at which this phenomenon is completed, it's called the austenite finish temperature, which means that at and above this temperature, the material will have completed its shape memory transformation and will display superelastic characteristics. The different temperature-related phase transformation of nickel-titanium alloys can be studied effectively by using these differential scanning calorimeter curves. In this graph, a bit modified by Sen and colleagues, you can clearly see that different nickel-titanium instruments have different austenitic finish and martensitic finish temperature. Until 2012, most of the endodontic engine-driven nickel-titanium instruments available had an austenitic finish temperature below room temperature, meaning that at clinical relevant temperatures, almost all the available files to work with were mainly in an austenitic state. Just like this file. This is a race, 3004. It's an austenitic file, conventional nickel titanium. One way to transform this file temporarily to martensite is to bend it. So you bend the file, you temporarily transform it to martensite, you release your hand, and the file springs back to normal and is again austenite. The other way to transform this austenitic file to martensitic one is by cooling the file. With endo ice, if you spray the file, you will transform it to martensite and the file will lose its shape memory. Now, as the file is heated back to room temperature, it regains fully its superelastic characteristics. So, conventional nickel titanium files and some heat-treated nickel titanium files, they all have restoring force. But what is so bad for a file to have restoring force for a curved canal trajectory? Check out this video. I made this simple experiment. This is a conventional superelastic nickel titanium file. Actually, it's an F2 rotating around a curve. You can clearly see that this file transports the canal towards the outer canal wall. You can all focus where this file touches the canal walls. In the apical third of the canal, it transports towards the outer apical wall, and this creates a vector of transportation at the middle third of the canal towards the inner canal wall, towards the inner curve. But you know, in endodontics, the inner curve, we call it the danger zone, because always at this point, the dentinal thickness of human teeth is minimal to start with. So in complicated canals, highly curved and double curved canal, we want to stay away of the inner curves. Why? Because if you remove dentin from the inner curve, you will straighten the canal, like my German friend in this case. This case was published in a German journal with the title, How to Deal with a Double Curved Canal. What this dear doctor did, he started with a double curved canal and some supracrestal coronal structure, right? And he transformed the canal to the shape of the instrument. But we need to do the other way around. We need to transform our instrumentation techniques and instrument to the initial canal trajectory and not transform the anatomy of human teeth to the shape of our instrument. And we need to be able to stay away from the inner curves. What it means, stay away of the inner curves. Check out this case by my friend from Spain, Xavier Pascual. Xavier from Spain is a highly skilled endodontist. And in this very difficult case, because of the restoring force of the instrument, I think these instruments are M2 instruments, he perforated exactly at the inner curve, because always in complicated anatomies, in the inner curve, we have minimal initial dentinal thickness to remove. So if you cannot stay away from the inner curve, probably you will result in perforation or strip perforation. Of course, Xavier Pascual is a highly skilled endodontist, and he managed to find the rest of the canal and obturate with MTA like this. Not all of us have the skills of Xavier Pascual. So in complicated anatomies like this one, we need to be able to stay away from the inner curve. So, what is the difference with the high flex? So, the high flex is being made with a special thermomechanical processing. And what happens with this thermomechanical processing, contrary to the conventional nickel titanium files that they have an austenitic finish temperature at or below room temperature, the austenitic finish temperature of the new control memory files is clearly above body temperature. As a result, conventional nickel titanium files are in the austenitic phase during clinical use, right? While control memory files are mainly in the martensitic state. And when the material is in its martensite form, it is soft, ductile, can easily be deformed, and is devoid of any safe memory. In 2012, for the first time, these files were introduced. This is a HyFlex 3504 file. The difference is huge. With these files, you can bend them, and they stay like this. They don't have restoring forces. It seems that you have a very flexible and pliable alloy, right? You can bend it that much. Okay, so you tell me, okay, Antonis, I can bend this file. So what? What does it mean for me to have a file like this without restoring force rotating around the curve? Check out this video. I made the same experiment with the HyFlex CM3004 without shape memory. The HyFlex is rotating inside the curve trajectory. You can all focus at the point of the inner curve, of the danger zone. You will clearly see that the file stays away from the inner curve. It will never touch the inner curve. And this is, if you want my opinion, what is the clinical difference of working with files without restoring forces, is that these files manage to stay away of the inner curve. And if you manage to stay away of the inner curve, you can create miracles, like my friend Arkadiusz from Poland. This is what he did. Arkadiusz, I was in Warsaw some years ago. We discussed control memory instrumentation, and then Arkadiusz sent me these X-rays. He managed to follow the anatomy and still preserve the dentin in the inner curves. We all would like to perform like Arkadiusz here. And this is the clinical difference. And you can find support in the literature. Control memory files in a double curve canal will always have significantly more transportation at 0, 1, 2, 5, 6, and 7 millimeter, always in the outer canal curvature. But the problem in endodontic instrumentation of complicated canal system is the inner curvature. This is where I don't have enough dentin to remove, not the outer curvature. While the vortex group, which is a heat-treated file, but with restoring force, removed significantly more resin from 1 and 4 millimeters of the inner apical curvature, of the danger zone. For the self-adjusting file group, check out this, had the most occurrences of excessive inner danger zone widening. You don't want to have, in complicated anatomies, excessive inner curvature widening, right? Nobody wants to have that. Moreover, a hybrid microstructure with a certain proportion of austenite, like the HyFlex, it's more likely to have more favorable fatigue resistance than a fully austenitic microstructure because of its dampening characteristics. Because at the same stress intensity level, the fatigue crack propagation speed of austenitic structure is much faster than that of martensitic ones. How much faster? 47%. A quantitative analysis, this is a paper from International Journal of Fractures, a quantitative analysis based on the model of fracture process zone shows that the martensitic transformation of superelastic nickel titanium alloys causes about 47% increase in the fracture resistance. This means if you have the same file and you can have it in austenitic structure or in martensite, will have 47% better, it will be 47% better in fatigue resistance, just because of the metallurgy. Very recently, you all know, I believe it's not available in some countries. In Argentina, it's not yet available, but it will come. Very recently, electrical discharge machining of control memory file became available. Electrical discharge machining is a non-contact surface treatment consisting of melting and evaporation with electrical sparkles of the metal surface for the machining of the flutes of the files. And although this procedure is well known for the manufacturing and carving of complicated shape in metals and in medical devices, it is the first time that this technique is being used for the manufacturing of endodontic instruments. Under the scanning electron microscope, you can see the difference between control memory CM files and electrical discharge machining files. While control memory files are a mixture of martensitic B19 monoclinic crystallographic structure and austenitic B2 cubic crystal structure, electrical discharge machining will result in a mixture of martensite and rhomboidal R-phase with a higher austenitic finish temperature compared to CM. And although recently evidence became available suggesting reduced fatigue resistance of rotary instruments in body temperature, this should not be the case for high-flex CM and EDM file, because the austenitic finish temperature of CM and EDM files is clearly above body temperature. It's around 43 to 55 degrees Celsius for the control memory files and over 60 degrees Celsius for electrical discharge machining files. So, if you want your file to be flexible inside a very complicated trajectory, either you use a control memory or an electrical discharge machining file with austenitic finish temperature far above body temperature, or you can use whatever file you like as long as you keep your files in the fridge in order to be flexible. Electrical discharge machining, you can see here the difference between, under the scanning electron microscope, between the high-flex CM and EDM. In the first row, it's the CM, and you can see the very smooth surface of the CM, and you can see in the higher magnification the striations that comes from that they are being produced from the grinding wheel, because the high-flex CM is grinded. We make the flutes of high-flex CM with a grinding wheel. On the contrary, the surface of the EDM looks like craters, because the EDM file is not grinded. The flutes are made with electrical discharge machining with sparkles, so you can see these craters in the surface. Now, if you take control memory files and instead of grinding the flutes, you make the flutes with electrical discharge machining, what you will get is that you will get instruments of extreme surface hardness, extreme fatigue resistance, high angular rotation to fracture, and a higher austenitic finish temperature. But the torsional resistance will be similar to other files. And sometimes EDM files may also have lower maximum torque load to failure. So, the lack of restoring forces and the fatigue resistance of control memory and EDM instruments render them ideal to be used in complicated canal systems, especially if you are using these files with a new instrumentation approach that we're going to discuss, that can compensate for the torsional resistance of these files. So this new technique that we are going to discuss is taking advantage of the properties of control memory and EDM files and compensates for their torsional resistance. What is this technique all about? So if you have a file, hand file, this hand file can be considered as the projections of your fingertips, right? Now if you have a rotary file and you mount it in your motor, then you can consider the mounted file like similar to a painter's brush. The only difference between our brush and the painter's brush is that for our file to paint the root canal, we need to press the button. We need to activate the file. It's not enough to touch your file inside the canal in order to instrument the canal, but you also need to activate your file. With a file that is non-rotating, not activating, you will have a tactile sensation of the anatomy, right? When you insert this file inside a canal. The factors affecting the tactile sensation of the anatomy you have are all these factors that you can see in your screen. It's the canal shape, the length, taper, curvature, content, possible irregularities, or the type of instrument used. Now, the tactile sensation that you will get with a passively inserted file, which means a non-rotating file, is determined by the frictional resistance generated when the file engages the dentinal walls, right? With the rotating file, you have a different tactile sensation. You don't have the same tactile sensation. The tactile sensation you have with a rotating file as the result of cutting can more accurately be determined by the ability of the file to resist advancement around curvatures while in action. So you have two different kinds of tactile sensation in your hand. One with a file that is non-activated and the other with a file that is rotating. What is tactile control activation technique? It's the activation of a motionless, non-rotating, engine-driven file only after the file becomes fully engaged inside the patent canal. Tactile control activation technique utilizes file activation only after maximum engagement of the fluids is reached and a tactile sensation of the anatomy is felt. Let me explain a little bit more for you to understand. Let's say we have to shape the highly curved mesiobuccal canal in this first maxillary molar. And we want to drive a glide path file. This is the HyFlex EDM 1005 glide path file. We want to drive this file to length with tactile control activation. How to do it? So you take the file outside of the box. The file is pre-sterilized. You place the file in your motor, in your handpiece, and you insert the file inside the canal, but without pressing the button. Don't press the button, without activation. If you do this, the file will move up to the point P, without activation. And this is the point that you will feel frictional resistance. You will have, at this point, a tactile sensation of the anatomy. At this point, at the point of maximum engagement without activation, you press the button, then the file starts to rotate. And then you push the file up to the point A, which is the point of maximum resistance with activation, and then completely redraw the file outside of the canal. Don't redraw the file and push it back again in with rotation. You have to remove completely the file outside of the canal. So with this technique, you only make one insertion at a time. not a second one. You are not brushing, we are not pecking. Insert the file without activation until resistance, press the button, move it until resistance with activation, and take the file completely outside of the canal. Stop the file, clean the flutes of the file, irrigate, recapitulate. The second time that you will place the same way, the same file in the same canal, you will feel resistance a little bit deeper inside the complicated anatomy. The new point of resistance will be closer to your length now. And you activate again at this point, move it to maximum resistance with activation, and take again the file completely outside of the canal. Don't redraw your hand and push it back again in. You finish your preparation with this technique whenever you will be able to drive your file to length without having to activate the file. If you can drive the glide path file, the 1005, to length without activation, then you finished with this file. You move on to the next size. And my favorite sequence to use in all the complicated anatomies that you are going to see, everything you are going to see was done with this sequence. After flaring, and sometimes flaring is optional, you can scout the canal and create a manual glide path up to 1002. You need at least 1002 for this technique to work. And then you drive with tactile control activation technique all files to length. So it's a single length technique. The first file, 1005, after 1005, 1504, 2004, 2504, 3004, 3504. And if you think that this sequence is difficult for you to remember, I got some news for you. It's the simplest sequence to remember because it's ISO. It's standardized. After 10, you use 15, you use 20, you use 25, 30, 35. If you want more, you take 4004, 4504, 50 or 6004. So you always know what you are using inside the canal. It's like using hand files, only you are using rotary files with control memory activation. You don't need to make notes. You always remember, after the 1005, I use 15, 20, 25, 30. If I want more, I move to 35. If I want even larger apical preparation, I go to 40, 45, 50, or 60. All 04. I'm not using in complicated anatomies tapers larger than 04. Now, not all anatomies are complicated like the mesio-buccal canal system of this tooth. For the simple anatomies, very soon it will be available even in Argentina. The one-file system by Coltene, the EDM, one file, it will be available, the one EDM file that is a 2508 in the apical 5 millimeters, and from D5 to D16, it goes with an 04 taper. So it's a variable tapered file. It's electrical discharge machined file. It's control memory, which means that you can bend it and stay bent without restoring force, right? It's extreme fatigue resistance, and that's why this file can be used as a single file technique in easy anatomies. Let's see now what can you do, the clinical application of this technique, of tactile control activation technique and this sequence in clinical cases. The first application is for smooth curvature and double curved canals. Let's say we need to shape these highly curved buccal canals of this maxillary molar. In this case, exactly with the same sequence, I managed to achieve an apical enlargement of 30/04. The technique, the sequence is always the same. You can see in this video the advantage of working this way. Tactile control activation technique gives you the advantage of pre-bending the file, make your way inside the anatomy until resistance, then activate the file, move it to resistance with activation, and take the file out. And this will be the result of a 30/04 enlargement in the highly curved mesiobuccal and distobuccal canals. This is a video. I hope that you can see this video. Maybe you can see it frame by frame, but you will understand also the technique. This is a maxillary premolar with two buccal canals joining each other. So, with tactile control activation technique, you can pre-bend the file, you have visual notification of canal negotiation, insert the file inside the canal. Without activation, the file is not moving. Then, in maximum engagement, activate the file, move it to resistance, and take it out. Don't push the file back again. You are going to break the file if you push the second time in complicated anatomies. With this technique, you only make one insertion of the file every time. If you go back to your practice and think how you break files, for those of you that broke at least one file, you will remember that you never broke a file in the first insertion. You always break files when you redraw your hand and push it back again in. With this technique, you redraw the file, clean the flutes of the canal, and then insert the file the same way. You can hear some sound of my clinic here that I forgot to erase. Anyway, what you can see here now is a different kind of irrigation. Whenever I have two canals joining each other, what I do, I use the Roeco microsurgical tip in one canal and I inject sodium hypochlorite in the other canal. So with this technique, I have fresh new irrigant circulating all around the anatomy. Okay? I'm fitting the capillary suction tip in one canal and injecting sodium hypochlorite in the other. It's a very, very efficient way of cleaning the whole anatomy. This is very simple to do in all cases of joining canals. Very effective, very simple. You will never extrude irrigant outside of the canal and you will have this result. This is the post-operative X-ray. So, in this transparent teeth, you can clearly see in this video how effective this kind of irrigation is. You fit the Surgity Pendo in one canal, you inject sodium hypochlorite in the other canal, and this creates a huge flow of fresh new irrigant throughout the whole anatomy. It's always, all the cases you see now, all these cases were done exactly with the same sequence. 1504, 20, 25, 3004 in the mesiobuccal canal system of this first maxillary molar, the highly curved. It's very predictable. It gives me always the same result. In this case, I stopped to 2504. Nowadays, I would move to 3004. This is 3504 in the palatal root of this maxillary premolar. This is 4004 in the distal root. This is 2504. This tooth is there only to hold a provisional prosthesis until implants takes its place, and the patient suffered for acute pulpitis, so I had to do something about it. And I've seen this very interesting anatomy. With this technique, you can have a 2504 enlargement very predictably, very safely. The sequence is always the same. Create a glide path up to 10, and then 1504, 20, 25. In this case, I stop to 2504. In some cases, you can move to 30 or 3504. Here is a 4504, 3004 enlargement. So with this technique, you only need to choose where you stop. You need to choose the size of your final apical enlargement. The rest is simple. You start with 15, 20, 25, 30, 35. Just choose where to stop. This is a 3504 apical enlargement in the distal root of this second maxillary mandibular molar. In this radix endomolaris case, highly curved 3004. This is a 3504 in the double curve, both double curve canal in the mesial root with tactile control activation technique. 2504, always the same, 15, 20, 25, 30. Usually in double curved canals like this one, I stop my instrumentation to a 3004 and you have a conservative shape that respects the anatomy. Very predictable, always the same, 3004, 3004 again, all anatomies with the same technique. In this case, I had two broken fragments in the mesial root of this highly curved mandibular molar. And what I did here, again, whenever I have broken fragments, first I bypass the fragments with hand files, and then I use tactile control activation technique to shape the rest of the canal, to enlarge the space that I managed to bypass. What you need to do, you need to insert the file without activation below the level of the broken fragment, and then activate the file and move it outside of the canal. Sometimes with this technique, you may see the broken fragment moving also, if you are lucky, outside of the canal. In this case, this was the result with control memory files. Very difficult case. I didn't make any kind of attempt to remove the broken fragments. I just bypassed both of them, shaped with tactile control activation up to 3004, and this is the postoperative radiograph. Delacerated canals, like this one, you can go up to 3004. You see, with this technique, you finish your preparation whenever you are able to drive your file to length without activation. And you can take also a radiograph, and you can see clearly in this sequence of radiographs how well it follows the anatomy. And this is a case, this is not my case, this is a case done with the same technique by my friend Andrea Minella, Russo, a very talented clinician. Through minimal invasive access cavities. You know, recently minimal invasive endodontics became rapidly very popular, especially in the United States and in the Eastern European countries. I don't want to get into the minimal invasive controversy in this lecture. However, if you like minimal invasive endodontics, I would suggest to use only control memory files. Why? Because these are the only files that you can pre-bend them, make your way inside the anatomy, and then activate the file. And with this technique, tactile control activation, you can have this result. This is a 3504 apical enlargement in both mesial canals, and in the distal root, you have a 4004 apical enlargement through a very conservative access. I think the minimalistic endodontists, they call this access opportunistic access. how to use tactile control activation techniques and control memory files in apical splits. Let's say you have a complicated anatomy like this one. You have one canal at the middle third of the root, it's dividing in two branches. How can you drive a conventional nickel titanium file inside such aberrant anatomy? I mean, you cannot achieve here straight line access. With control memory files and tactile control activation technique, what you can do is you can pre-bend the file, make your way inside the canal without activation, and at the point of maximum resistance, activate the file, move it to resistance, and take it out. And with this way, I managed to have this result. Actually, it wasn't 2 canals, it was 3 canals. And I managed to shape them to a 2504 apical enlargement with this technique. And obturate with single cone and sealer, and this is the 1-year follow-up. Or cases like this. You have one canal, you want to create a minimal invasive access cavity. The canal is dividing in 2 canals. How you are going to enter to the difficult lingual canal? Check out how abruptly the canal curves at this point. What you can do with this technique, you can pre-bend your file, make your way inside the canal without activating the file. This is the glide path file, EDM file, 1005. The file is completely engaged inside the trajectory. Activate the file and take it out. Don't push the file with activation again in, you're going to break the file. With this technique, you only use one insertion at a time and you will have this result. Unfortunately, in this case, I had a minimal access and I pushed a lot of sealer outside of the canal, but it seems like healing is uneventful. So I would like to discuss with you this last case just to show you the limits of this technique. I mean, with this technique, you can manage all difficult anatomies, very difficult anatomies, even like this one. Check out this one. How are you going to shape such a delacerated canal system without destroying this root, perforating, or breaking an instrument inside? With tactile control activation technique and control memory files. Let me tell you what I did here. If you want to create, if you want to treat this tooth, you have these 4 problems. First is the access to the canal. Second, to achieve technical patency to the canal terminus. Then to shape the delacerated canal to a desired width that you can disinfect the apical third right, and then how to obturate predictably a case like this. Access to the canal in a case like this is not a big issue, but how to achieve technical patency to the delacerated canal. What you need to do is you need to pre-bend the apical third of your hand file, make your way inside the anatomy until you meet resistance, and then slowly rotate the pre-curved file until you find the entrance to the rest of the canal. Once you find the entrance to the rest of the canal, then somehow you have to move this file to length. The movement that I'm using is, you can find it in the literature as watch winding pull movement. So you rotate around 30 degrees clockwise, 30 degrees counterclockwise your file by maintaining a smooth apical pressure, and pull your file, remove the dentin, and again, watch winding and pull motion. This way you can drive your file to length, even in complicated anatomies like this. So with this way I managed to drive 06 to length, 08 to length, and ISO 10 to length. Now the big problem starts. How are you going to enlarge this double-curved canal? Let me show you how I did it. This is the image of my hand files after using them in an anatomy like this. You can see the plastic deformation of the hand files, stainless steel hand files, that replicates the anatomy. So, in order to enlarge this highly curved canal system, I used the 1005 EDM file, which is my magic file in very complicated anatomies. What I did here is I pre-bended the file, insert the file. This is a graphic made for me by Orosi in order for you to understand what is going on. You pre-bend your glide path file, insert the file without rotation. Don't activate control memory files outside of the canal. Insert the file until the tip of your file goes below the abrupt curvature, and at the point of maximum engagement, activate your file and take it outside of the canal. The second time you are going to insert the same file the same way, it will go deeper inside the apparent anatomy. The third time you will be able to drive this file to length without having to activate. This means that you will be able to do this. Drive a 1005 to length without having to activate the file. The rest is simple. After 10, 1504, 2004, and I stopped here 2504. If you stop in 2504, you take a hygienic 2504 GP cone. You can enhance disinfection, agitate the irrigant with a manual dynamic gutta percha agitation technique. This is the safest technique to activate the irrigant in such difficult anatomies. And you will have this result. You can find this technique very well described in the paper that was published in the International Endodontic Journal under the title of Root Canal Treatment of a Delacerated Mandibular Premolar using a Novel Instrumentation Approach. Of course, for those of you that will attend COSAI meeting or that will attend my lectures worldwide, you will have the chance to practice the technique, and you will have the chance to see a demonstration of using this technique in order to navigate around very complicated acrylic blocks and complicated canal systems. And these are some cases, only radiographs, that you can see what you can do with this technique. Very complicated anatomies, like this one, all were done with this technique. Even delacerated canals. I got a lot of stuff to show you. They all were done with the sequence is always the same. You can never forget the sequence. 10, 15, 20, 25, 30, and so on. You just choose your final enlargement. How to drive your files to length in an anatomy like this with tactile control activation technique. Insert the file without activation. Sometimes you need to pre-bend the file in order to navigate around the abrupt curvature, and then activate the file and take the file outside of the canal. Third molars, very complicated canal system. Check out this. This is the mesial root, a 3004 enlargement, and a 3504 in the distal root. It's always the same, very predictable, always the same technique. I truly believe there are many techniques to manage anatomies like this. However, the only thing I can do for you is I can share with you my technique. My technique, I hope you understood my technique, and I hope it will work in your hands. For me, it's very predictable. It gives me always the same result. You see, always complicated anatomies. I don't have the time. We could spend one day here discussing about this and showing you case. So I would like to make some concluded remarks for you before I finish this presentation. So with tactile control activation technique for engine-driven nickel titanium file, you can minimize the time of engagement of the activated file in a complicated canal trajectory. The TCA approach is suggested to be safer than brushing or pecking because a single file insertion is used every time, and the file is always withdrawn outside of the canal before reaching the maximum torque load to failure. Tactile control activation approach is suggested to produce less debris extrusion than any other instrumentation approach, since the files are removed after each insertion to be cleaned from the debris. With tactile control activation techniques, the file can be checked frequently for any possible deformation, resulting in the prevention of file separation. Tactile control activation technique is suggested to prevent also canal blockage in even the most challenging anatomies that you will encounter. And tactile control activation technique can also take advantage of the enhanced fatigue resistance of control memory files and compensate for their torsional characteristics. And I truly believe that tactile control activation technique is easily teachable and reproducible even from general dentists, and I will be more than happy to see, especially from general dentists, highly curved cases, complicated cases, saved with this technique and control memory files. You can send me in my email your cases, and I will be more than happy to show your cases in my lectures with your name. It will be a true honor for me. So I would like to thank you all. I hope you enjoyed this webinar. I hope I managed through the internet to be clear about the technique and how to use control memory files. Probably if you see me live, because I'm moving a lot and I'm making some demonstration, you will be able to understand even better, but whatever you would like to ask, you just mail me, Facebook message me, or whatever. You can find me. I may not be able to respond immediately, but I will respond to each one and all of you in a convenient time. Thank you all, and especially I would like to thank the team here. I have a lot of people here. I feel like a star or something, and I would like to especially thank Nicola Zotola and Lucas Beris and Coltene.Latinoamérica for doing such a great work. Thank you guys. It's been really fun to be here with you. Thank you.